the time to attend the presentation of our Health Humanities Portrait, Racial Disparities in Pandemic Care, and you got our teaching guide. We apologize in advance that we didn't get which readings we really wanted you to do out until Sunday, but just to reinforce, the three things we really wanted everyone to get through was the first person narrative, the Lancet paper on structural racism and health inequities in the USA, and then there was a historical paper on housing that Zaire found and also cut off for us. So if you saw, there was a line through it that said, it's optional reading from a certain point in the article, but those were the three major articles that we wanted you to go through in detail. And just, I think to begin, I think Sandy had said maybe we all know each other, but just to identify who all the presenters are, obviously I'm one of them, so Adrienne Tan, and I'm in Toronto. I'm a consultation liaison psychiatrist, and then maybe we'll go to Selçuk to introduce himself quickly. Unmute yourself, Selçuk.
Oh, sorry. Hello all from Turkey. I'm Selçuk Akturan. I'm a fellow. I was a fellow at UIC for 10 months, and now I am in my institution in Trabzon, Turkey. Yeah.
And then Zaire, do you want to go next?
Hey, I'm Zaire. I'm coming from Chicago. I'm an emergency doctor working at University of Chicago, and I'm also one of our education fellows.
And Laura, last but not least.
Hi everyone, I'm Laura Morton. I'm a geriatrician, associate professor at University of Louisville in Louisville, Kentucky. And many of you probably remember me for the very long time I've been in the program, and I'm excited to be here today.
Right, so I think we'll begin first by giving you sort of an orientation to the portrait and what it is, just in case people haven't had a chance to read Sandy and her collaborators' excellent paper that just came out. I found it on in Journal of Medical Humanities, so it's hot off the press. So we thought we'd spend about 60 to 75 minutes in the beginning portion presenting our portrait to you, have a little bit of a break where we can do some yoga, stretch out, run to the bathroom quickly, then come back and talk about sort of improvements, that's sort of the pedagogical piece of it afterwards. And so I'm going to go through just the introduction, and I'll quote directly in terms of what a portrait is from Sandy's paper. So a Health Humanities Portrait is a pedagogical tool that both enables health professions learners to examine pressing social issues that shape and are shaped by experiences of health and illness. The HHP's architecture is distinctly framed around a pressing social theme and utilizes a first-person narrative and scholarship to explore how the dimensions of the personal and the structural are mutually constituted. The HHP enables learners to become proficient in synthesizing and analyzing with both depth and breadth the human and social dimensions of patients' lives. And the purpose of it is to elucidate the multiple aspects of health, illness, disability, and healthcare. That is a brief guide to the HHP. And then there's a bit of an introduction in the beginning you see in the guide. We chose, of course, something very topical, racial disparities in pandemic care. And we'll go through a bit of the process of finding the narrative. We had a first person narrative, which we sent to you from the Detroit Free Press. And from that, we have three sub-themes: housing, medical access and quality of care, and police brutality. So after I finish the introduction, Zaire will proceed with presenting on housing. Selçuk will do the portion on medical access and quality of care, and Laura will speak about police brutality. In terms of our learning objectives, we had 4. I'm assuming you read them, so I won't go through those in detail, but I think what we really wanted to focus on in terms of our experience of the portrait was 2 things. One, yesterday, when we met as a group to sort of get together and refine what we were going to present today, we were reflecting on how different this is from our medical training. That these sort of the ways of knowing through the humanities course and the kinds of evidence were so novel to us in a way in terms of our training, even though some of us may have taken sort of humanities courses in our undergrad, it might have been a long time ago for us. So it took us some time, I think, to wrap our minds around all the different sort of disciplines. And of course, we chose to examine our topic based on history. And it took us a long time, actually. We struggled. So the 4 of us worked very hard to find a first-person narrative on disparities in pandemic care. And you'd think during COVID, you could find that. And even Sandy helped us, because in the end, I think we were starting to look a bit desperate. But we really searched and searched. And on all the blogs, we couldn't find anything about what we were reading in the newspapers. and what you were seeing in the media, which was that COVID was hitting certain populations more than others, but nothing of a first person narrative from anyone in those populations, until I think at the very last moment, I decided one last ditch search, right? And then, you know, I happened upon this paper in the Detroit Free Press, and I think we all breathed a huge sigh of relief that we found something, and this wasn't even from a patient, but from a caregiver, right? Because you saw it's Keith Gambrell, and he lost his father to COVID-19 after his father presented to 3 different hospitals and didn't receive care. And he notes in kind of, I think a little bit bitterly, that his father was treated differently than someone who was not Black, he implies, who ate bad sushi the night before and was provided care, but his father wasn't. And his father later died at home. And then his mother later was assumed to have contracted COVID, but also couldn't get care. So there were all of these issues, and you could see that eventually many members of the family were assuming, maybe who live in close proximity to one another, who maybe weren't able to physically distance, all contracted COVID in succession. And there's sort of very evocative imagery in his narrative of the experience with COVID-19 and accessing care, but also linking it to police brutality as other evidence of racism, and those two converging in a very sort of potent moment. And so I think in a way, it was fortuitous that we found this, because it brought things that I think were very topical right to the forefront, and allowed us, I think, to really examine all the different lenses, not just from the first person narrative, but the bigger historical context and of the structures that perpetuate the kind of sort of like structural racism that we're seeing in this moment. And so there'll be a lot more to talk about, but we wanted to make sure there was enough time for each of the sections. So without further ado, I will hand the baton over to Zaire to talk about housing.
Almost forgot to unmute myself. So I know the housing paper was the longest of all the papers that you got sent. And before we dive into kind of a deep look at what that paper kind of discussed and brought up, I wanted to first kind of pose a question to the group. You know, we chose 3 subtopics, housing one of them. And what the purpose of the HHP is to try to use this first person narrative that we found to kind of highlight some of the topics that we want to talk about. And I wanted to know if as you read through the first person narrative, how did you conceptualize, like, was housing part of that you took away, that you came away with the reading from, or was housing for you completely unrelated to what you had read? Because I would like to talk about housing, but if for you reading that story didn't relate to housing at all, I want to kind of first preface why I included it. So do you see how it was related to the story that we mentioned? And in what ways?
I guess I will say I didn't see anything explicitly in the article. I felt like it was maybe not clear that that was an issue for this family. However, it did make me think of an op-ed written by one of our graduates who had a patient that came to him and said, how am I supposed to social distance? This was a Black family on the south side of Chicago saying, how are we supposed to social distance when I have several people living in my family? All of them are essential workers. I don't know how we're supposed to stay safe. And so he wrote the op-ed because he felt really distraught in being able to respond to his patient appropriately. And so this is an issue that is very, very common in, I think probably in the neighborhood where it seems that this family was residing. So I think it absolutely is an issue. I didn't really see evidence of that within this family displayed in the article. So I did see a disconnect there, but I think it's a very important consideration that should not be left out, because I think that's a big, big thing that a lot of, especially more privileged people don't have the awareness of.
Yeah, I guess I made an assumption in reading the first person narrative that it might be true. This is sort of my bias about the city of Detroit, right? So I'll confess to that, is that this family probably doesn't live in the same kind of neighborhood that I live in, which I was pleased to discover in your paper that I live in an African-American community, Zaire. It's called Hyde Park. And so I made an assumption that if this family had been of a different socioeconomic status, that perhaps their Blackness might have been overlooked. And so maybe housing does matter.
Yeah, I think kind of underlying that paper are these kind of assumptions and implications. But yeah, it may not be super explicitly stated, but it obviously kind of weighs in on the larger like health outcomes of the African American Black communities in America, and specifically in the first person narrative. It's one of the many factors that I think ultimately led to this writer's father's death. And so I guess with that, I'd like to move into the actual, oh yeah, Sandy.
I noticed this was like I think I read it like 3 times, but it wasn't the narrative.
The narrative, yeah.
Yeah. I mean, I think he does explicitly call out housing, but he doesn't really explore it. But what I did think was interesting this time, the last time I read it, was that the son, who's the author, talks about how he rushed over to his parents' house. So it's clear he doesn't live with his parents. Maybe his brother did.
Yeah.
Who called him in the middle of the night, or right? But he has a separate residence. And so I started to think about housing in that way, like sort of in tandem with what Joanna's talking about, like the issue of what do? We can't social distance, but he himself was not living in that house. I don't know what the implications are for that, but it was like an interesting layer that I hadn't thought of the first time I read it.
Yeah, and similarly, when I had read it, he talks about how his brother called him, and I assumed, although I guess that's never explicitly stated, that the brother was living with the family because he was there and found the father at kind of an odd hour. It again wasn't explicitly stated, but that felt like part of the housing complications that were raised in the piece. And so, yeah, I'd like to move on to the larger historical housing article. I know it's relatively long and you didn't get to later. So I'll do my best to kind of summarize the main points of the article, but I chose it for a few reasons. One, I think it does a really good job of kind of historically outlining some of the major kind of racially motivated segregationist policies and kind of discriminatory policies and practices within lending and housing in general in America, and outlining that nicely. But it's also kind of interesting in how it's written and structured. And so if that's how I'd like to kind of start this conversation before we dive into the detail of the actual papers. But as you read it, did anything particular about the structure or tone stand out to you? And if no one read it, I guess I can give my thoughts.
Zaire, so are you asking about the housing argument in terms of how it's constructed?
Yeah, so I think there's a lot to it, obviously. I think first and foremost, I'd like to talk about, like how he constructed his argument. Did you have any kind of problems or critiques around the actual structure of what he was trying to say? And what do you think he was trying to say?
Well, I think my first reading of it, which I'll confess was quick,
as was mine,
is that it certainly provided plenty of statistical evidence and outlined a history of segregational policies and racism. But I think it lacked a way into it that individualized it. It just seemed to me that it wasn't it was effective, but not effective in getting me hooked on it. And so we could talk about that in the second stage, but right now it's just, there wasn't a way in, like you weren't following a person through a situation, right? But it was just an accumulation, like almost an avalanche of things that have happened historically.
Did you find that he was making an argument or just kind of listing a series of events?
Well, I think also, right, because I did stop at the blue line.
Yeah.
And so I don't know if it ends in a way, right, that ties it together.
Yeah, and I was like kind of going back and forth on that aspect, but we'll talk about it later.
Yeah, sure. We can do that on the second stage.
Yeah. What about his tone? Did that turn you on or off into the argument that he was trying to construct?
Yeah, I want to follow up on what Michael had just said. So the last phrase in the introduction to the chapter is, understanding the past is essential to understanding the full dimensions of the contemporary housing problem. Now, I understand this is the third chapter of something longer. Mm-hmm. And so I was left wondering, well, how is this author framing the contemporary housing problem? And I thought, understanding the past and understanding full dimensions sounds like a very intellectual argument, which I think, Michael, if I'm hearing what you're saying, is there's not a, it's a third person looking at a situation. I am not seeing people or characters that I can perhaps follow through a series of historical events.
The first point that you raised is actually very interesting, and I was going to circle back around to it, because you're right, understanding kind of his viewpoint in general and why this book was written it definitely changed how I kind of interpreted his entire essay. But this is part of a book written in the late 90s by this author, Roy Brooks, who was attempting to make the argument that integration in America on kind of a larger scale has been a failure. And he's making a larger argument for what he called limited separation, which is kind of a middle road of structuring society between full integration and like separationist policy, because that was kind of always there's been a movement towards that at different periods of time. And so the way he kind of builds his entire essay is with that in mind. And I think reading it without that context, definitely I read it differently once I understood that that's what he was like getting at. Which is, I think the second or third time I read it, I started picking out like, oh, this is the tone that he's bringing to it. And there are a few moments in the reading that I thought were like kind of, interesting from a few different aspects, but I guess, well, just kind of marching through the paper, he begins discussing like the historical context of like American housing and like tries to bring it into kind of Black isolation today. And he starts off with a strangely kind of rosy picture of slavery and housing during like post-Civil War. Yeah. Sandy, I see you're saying something. You're muted though.
Yeah. I thought that struck me as like, okay, yeah, so people lived close to one another during slavery, but the power differential of that living closely is a little, and he doesn't unpack that. I don't know if that might just not be his agenda, but that did seem a little odd to me.
Yeah.
Although I wasn't as worried as Michael about not having the hook, because it's a very social sciencey kind of writing that I think in historical writing it's not uncommon. So yeah, go ahead.
Well, I think to that point, though, also is that with like, they weren't living in segregated neighborhoods when slavery was taking place, right? It's a curious thing to say, but it also is, it seems, and it's a problem throughout for me, is that agency on the part of the African American is not really presented in a way, in a sustained way, right? So right there where they're saying they didn't live in segregated neighborhoods, but they had to live there. And they're still having to live where the zoning codes are making them live, right? And so in some ways their agency still is being, there is no agency, I suppose.
Which is, I think, kind of one of the nice things about this essay. It does a very good job of kind of almost in a way equating the lack of agency during slavery to now. And one of the other things I think you could critique, or that I sometimes was kind of shocked by as I was reading this, was one kind of, you're right, the assumptions underlying like white intent, like he says they're conscious, like malicious efforts, and some of the people he quotes are like, oh, this is apartheid, and he references like Nazi kind of policies. So it's very strongly worded, which I think I kind of enjoyed, or like drew me into it at least. But I could see how that might turn other people off. And so I guess I brought up tone because I was wondering if anyone came away being like, I felt like I was being like kind of yelled at the whole time, or like turned off in some way because of his tone. But it doesn't seem like that's the case, which is interesting. And so he begins with the historical context, and there's some weirdness to that, and then moves on into the kind of history of housing, and certainly we can talk about some of the details there, but I think he does a good job of kind of highlighting some major policies that have led to like segregation as it currently exists in America. One of the interesting sections was the like effect of housing segregation on today, and he talks about how housing discrimination and segregation leads to poverty. And I thought his argument there was interesting. I'm on like page 51 now. What did you make of that kind of tie that he tried to make between how housing drives poverty and the other kind of social ills of segregation?
Educational opportunities are tied to housing. And so for me, he's making a very effective case on the structural racism that prevented people from having upward mobility. And, we still are dealing with the issue of property taxes and equity in terms of, public school funding. But I think it's always been a pretty tight tie.
Yeah, in the middle of 53, he kind of goes beyond just education. He says crime, violence, housing deterioration, mortality, welfare dependency, family structure, joblessness, these are all kind of tied together, and it brings in this kind of aspect of intersectionality into this whole conversation that I think is very important. And that was like, even as I was reading through it, I highlighted that paragraph like 8 times essentially. I think one of the other things
Sorry to interrupt. I think I saw Janet and maybe Sandy's hand go up.
Oh, sorry. I'm looking at the paper as I'm talking.
So I I have to confess that I barely skimmed this article.
That's fine.
However, on this topic of poverty and segregation, I mean, there are, this is also a chapter in Kendi's book, How to Be an Anti-Racist, which is devoted to the spatial segregation. And one of the points that he makes, I believe I remember, is that by privileging certain spaces over others, it really makes the economic disparities more enforceable, more efficient.
Well, and to that point, I think what I picked up on is opportunity hoarding, right? Where a lot of these things are set up so that white neighborhoods have the best schools and the most taxes are going to them and such, right? And so it's all these ways in which opportunities are being hoarded by those with the means, right, at the exclusion of others. And so, you know, making sure that their school systems, and I recently read White Rage by Carolyn Anderson, who I think is a fantastic book in terms of laying all this out. And so that's kind of also inflecting how I'm reading this.
I was just going to point out the pages that you're referring to on the side. What I did was I said there's a dose effect, right? So he's talking about Massey and Denton, I think, their study, and showing the as the dissimilarity gets larger, I think. I forget.
Yeah.
Right? That there's a dose effect, right? Of the impact it has on opportunity or on all these other sectors, right? Which I found to be very powerful and very convincing, even though I haven't read Massey and Denton. Just his treatment of it was quite good, I thought. And I really enjoyed his calling out of class. In other words, that racism and class are completely and totally intertwined. And this isn't really about, I mean, it's about race, of course, but its grounded sort of implications are class-based. And that's so overlooked in, you know, there's a whole literature on this about how class gets overlooked as sort of a variable, in part because we like to think, Americans like to think that you can transcend class. And so, you know, a lot of the conversation gets stuck on race when really what we're talking about a lot of times is the intersection of those two things. So I thought that was really good. This section of the chapter is really, really powerful.
Yeah, and I guess we're running a little short on time, but I think he addresses directly the class argument kind of in the subtitle, discrimination as a primary cause of segregation. But I think the other really interesting part to me, or another concept that he kind of mentioned, was this, and I'm probably not saying it right, but the like GoTro program in Chicago, which at first I wondered why is he including this? And then in kind of top of page 57, he starts talking about, or starts citing others who have critiqued this program. And just to summarize for people who may not have gotten to this part, it sounded like this program was instituted in Chicago as a response to kind of a lawsuit that took place because of housing discrimination, and the program provided Section 8 housing to a small number of people every year. And then there have been studies on, like, kind of qualitative studies interviewing people who moved from kind of impoverished Black neighborhoods into other neighborhoods, whether they were like middle-class Black neighborhoods or kind of middle to upper-class white neighborhoods, and then saw kind of looked at their experiences with that. And one of the most interesting parts of the studies that he mentions there is how, and I want to say he calls it like cultural kind of discrimination or cultural alienation is a large part of integration in this aspect that can't be kind of ignored. And I just wanted to mention that as one of the other concepts that I thought was interesting. But I think to end, the conversation about housing, I know we kind of got in the weeds of history and statistics, but to bring it all back, like how, after you read this, granted everyone's knowledge of housing and discriminatory policy in America is different, but did a fuller understanding, as he kind of proposes at the beginning, did that paint how you then saw Gary Fowler's death in the primary narrative? And how does it change it?
One thing that, so when the father comes home after trying to get treatment at 3 different hospitals, right, he breaks down, he says, they're going to let me die, right? And so I'm wondering, I mean, it's kind of like they're going to let me rot. I mean, it's kind of like, I don't know. That's when I saw that there was a very much a kind of not an acceptance, an acknowledgement on his part that this is just another time that, right, where the services aren't available or what have you, but this time he's probably going to die as a consequence of it. I mean, I think there's a kind of
not again.
What's that?
Like oh, this is going to happen again. Not
yeah.
Again as they're going to leave me out to die.
Yeah. I mean, it's like, I think he fully recognized what was happening, right? That it was that he's Black and poor.
And the injustice of it, to me, that I'm going to I was trying to put myself, like, if I were desperate, right, and trying to seek medical attention and I was turned away 3 times, I would say to my partner, oh my God, they're going to let me die. Like, this is so unjust. This is just like, yes, a continuation, but like, wow, the injustice of it. And I think that's the way that the son is connecting, and we'll get to this, Laura, the police brutality stuff. It's like this just injustice, right? And it's long-standing injustice that we're now seeing over again. But yeah.
I think the power differential and the powerlessness of being able to change and fight these historically, pervasive structural barriers is part of what you come away with. They've lived this, they know the data, they know the history, whether they know it explicitly, they carry it with them. And I just think that sense of powerlessness, that he fought and fought and fought to get care, and he was turned away, and he feels like there's nothing else he can do.
I was struck too, and this was an assumption that I made when I looked at the first person narrative again, and noticed especially that the mom had gone to a hospital where she saw a presumably rather affluent young white woman being treated for, eating bad sushi. And I thought he must have gone to hospitals in various places. That is, that he tried a hospital near him, he tried hospitals further away, and could get treatment at none of them. Neither the hospitals that might have few resources and therefore be limited by simply the resources within the hospital, nor the better resourced hospitals would treat him.
All right. Yeah, I mean, I agree. Oh, yeah, Sandy.
I'm just going to get back to your question, which is like, how do I now think about the first person narrative in light of this understanding of sort of 20th century, particularly 20th century policies and practices, racist policies and practices of the state and also of just citizens. And I think it really did bring a lot more understanding for me about how embedded and sort of, I don't know what the word is, but embedded these practices are, right? And that there's a reason why this story happened, right? And it's not necessarily a very recent reason. It's the accumulation of these policies over a century.
I wonder if deservingness is one of the things that may have played into this man's story. That if he went to a hospital outside of his own the place where he lives, if he was denied resources because of a sense of not deserving. Anyway. Because of the housing inequities that
right.
sort of force people to recognize structurally that there is a place where one belongs and there are places where one doesn't belong.
And to that point, I mean, I think, and this is both the story, the first person account, and then the housing chapter, I think does do a very good job of pointing out what structural racism is. I mean, how it is built into so much of a culture, right? That, I mean, it's systemic. I mean, so I think it does such a good job of pointing that out. And we'll talk about that. I'm making notes for stuff to talk about in part 2.
All right. Well, thank you. I think that's my time for housing. We'll now move on to medical access, I think.
Yeah. Hello again from Turkey. Yeah. I'll talk about, for me, in order to understand disparities, I think we should think on some important issues like inequalities in healthcare access and quality of healthcare support. And I will talk about the disparities on healthcare access and give some details, some main points of articles about the healthcare access. And I will share also, I put on the guide an additional Detroit Free Press article, which has some more details about this situation, this tragedy, an interview with Gary's son, Kate. So I will share some details to support our discussion. And also I want to say that the COVID-19 came from Gary's father, David. And Gary, he was 76, and Gary visited his father when he was camping in the middle of March. And then one day after his visiting, David's illness was began, and then illness was serious and passed out in one day. Interesting. Then they called 911 and went to the hospital, and he tested positive for viruses. The following week, after the passing away of his father, Gary has cough and other symptoms of coronaviruses, and he said when he goes to hospital that my father was dead because of COVID-19 1 week ago, and I have also shortness of breath and fever, but they just said him that, sir, more than likely the fever is from bronchitis. And they said some advice and tell him to go home. So, but Gary was not tested for COVID-19. It's interesting. So I just want to start with the question that what do we know about inequalities as a result of racism on accessing healthcare during COVID-19 pandemic? I just want I'll just try to find some information for this question, but if you have any additional data, please share with me. Yes, we know also some fault lines in society, but COVID-19 also, this pandemic has revealed the existing fault lines in society, socio-demographical, social, racial and ethnic disparities also characterize population at greater risk for COVID-19. Gary Fowlett also faced racism during seeking healthcare with COVID-19 symptoms in an emergency situation. And unfortunately, he died at the end of this tragedy. Besides, his son shared his father's story to raise voice for inequalities and stop the racism. He also says in interview that I just felt so bad because he was begging for his life and medical professionalism, but the medical professionals did nothing for him. Yes, the health inequalities is heavily influenced by race, ethnicity, and culture. While COVID-19 continues to spread throughout the world, the first data from the United States show that minorities, especially Black people, are infected and killed disproportionately across the country. And the latest data from Central Disease Control of Prevention also support this situation. Dr. Khaldun, a chief medical executive for the Michigan Department of Health and Human Services, also important person, said in an interview that about 33 of the cases of COVID-19 in this entire state of Michigan are in African American, and about 40 of the deaths also. This is incredible concerning. We know that African Americans are just 14% of Michigan, the entire population of Michigan. Yes, for Illinois, it's also, I have some interesting information that 37% of confirmed cases and 45% of COVID-19 deaths are African Americans. but they are just only 16% of state population. Yes, also this ethnic minorities face economic and social inequalities through life, resulting in low access to healthcare and used healthcare system. For example, the elderly Hispanics and Black people are more likely than whites to delay or not to get their needed healthcare and have less dental visits. Also, the current COVID-19 pandemic aggravates this situation. At this point, also another question arises in that how does racism affect quality of care? Yeah, as we know, Gary Folt registered 3 times to different hospitals with COVID-19 symptoms, but none of them had treated him. Also, the elimination of disparities is not important just for inequalities, also important for quality of care, healthcare system. We know also that Black people and other ethnic groups and Hispanics were found to high risk of in-hospital COVID-19 death due to the deprivation of healthcare opportunities compared to white people. And I just want to say that not just for COVID-19 pandemic, it's also similar for other infectious diseases and AIDS, HIV. And also at this point, Dr. Khaldun added that we know there is often delays in diagnosis for all kinds of medical conditions in the Black community and people of color. So are there delays in testing, or are there delays in treatment? Are we sending people home when they really should be admitted to the hospital because they are so at risk for deteriorating quickly? So those are the types of things that we are going to have to look at. And again, they are happening with other diseases also. And I'm sure they are happening during this COVID-19 pandemic right now. I'm not sure what is the problem, the main problem, but I think these are the problem has been created by the integration of all aspects of healthcare system, testing, treatment options, maybe after the treatment period, the prevention of other. Yeah, please, Sandy.
So I wanted to speak to the questions that you raised in the teaching guide and today in your review of this issue of access to care. And I was just skimming the article, the subsequent article that you were talking about. And what's so interesting to me is that it raises the zip code, right?
Yes.
And so that really connects with Zair's discussion about housing and sort of the geography, what we call the geographies of disparities or geographies of care. And by the way, there's a whole field called critical medical geography that looks at these kinds of issues. And so, so that's number one. And number two, you know, so I think it would be, and we can talk about this in the second hour, but to make this link explicit between housing and access, but also that it raises the issue of, or that you have raised the issue, that medical professionals themselves did it. Like they deny, at least this article makes it seem like they themselves denied the care. And certainly they're part of the hospital system, and the hospital system has power over who is going to be excluded and included from care. But I think it invites a really, well, and then I have another thing I wanted to say, but it invites a really rich conversation about the Hippocratic Oath, right? And the commitment to care. And then what happens in a time of scarcity, which is, does that Hippocratic Oath change? And also that physicians and other medical workers are working within a system where they don't have necessarily the kind of power to, they're working for hospitals and hospitals in the United States are profit making. And so, what is that overlay doing to the story and to the, and Christy, I know you've thought a ton about this, right? So that there's certain dynamics also that are happening that are unsaid and unseen that affect this story.
Yeah, absolutely.
I'm wondering, Christy, what do you think? Like, what are your thoughts about just being so embedded in these kinds of questions already?
Am I on mute? I think I'm on mute.
No, now you're fine now.
We can hear you.
Okay. So that was a broad question, Sandy. So, in terms of, well, I have thought about this a ton, and my mind is in a million different places. What specific point would be most helpful for me to address, do you think?
I guess I was thinking about 2 points, the sort of ethical, obligations, but how those ethical obligations change with conditions of scarcity. And then the second would be the relationship of health professionals with hospitals, that are these bureaucracies, and they're profit-making bureaucracies.
Right.
And so what is...
So one of the things that, we're not talking a lot about is how the triage standards have been written for crisis standards of care, and where's implicit bias in all of that. So, I think part of what's been really problematic is that implicit bias is particularly difficult because it's unconscious. And so there's still a lot of, decision-making that's allowed by the professional. It's supposed to be individualized, it's supposed to be at the bedside. But I think that, when you're looking at the fact that most people who go through these triage algorithms who are Black or Hispanic or disabled or older are people who come into that situation with historic disadvantages. So they may have more chronic illnesses. So immediately you've got a situation where people who've been historically marginalized are disadvantaged further because of the way the allocation is being done. And then you take the situation of the employer-employee relationship and the fact that most hospitals now are not run by doctors, but they're run by business people. And we're seeing that professionals who are speaking out or speaking up, talking about PPE, for instance, publicly, they're getting fired. So what does it mean to be a professional? Are you a widget? Are you, supposed to be a good foot soldier and just do what you're told? Or are you supposed to really be advocating, for the standards of care? So the moral distress and the burnout rates during COVID for health professionals are also very, very high. Then you got the OCR, coming along and saying, well, don't discriminate. A lot of my work has been around disability, but, they just basically say, don't discriminate. But they also don't talk about how do you provide those extra supports, resources, tools, for patients who come from disadvantaged backgrounds. And there's been this desire in COVID to try to get people to cooperate and work together, which is very difficult when historically they're used to being competitors and people don't want uninsured patients and they don't want Medicaid patients. So the ethics issues and the social justice issues permeate everything, I think, in COVID. And the structural issues are being made much more visible because of these kind of experiences. But one of the things, ethically that I would say is if you come from a disadvantaged background, autonomy doesn't mean much in the absence of social justice. And I will say that again, because I think this for me has become like sort of the big take home message. If you don't have reasonable choices, you have no options. Autonomy really doesn't mean a whole lot.
Yeah, amen to that, Christy.
And I would add, autonomy is meaningless in the absence of historical context, right? Because it is the historically disadvantaged populations, right? And so speaking about choices without considering historical context it's empty, right? You are shaped by, what your historical context has been, and the policies that have produced that. So yes, I think that's very powerful. I'm sorry, Seljuk, do you want to continue now?
Thank you for your contribution. Also, I want to add some information about the healthcare outcomes because of the ethnic and racial discrimination and maybe the cause of socioeconomic situations, such as high blood pressure, the high rate of high blood pressure, and obesity, heart conditions, and diabetes, and high cholesterol levels. These are the rates of these conditions are high than the white people's, and also black people are not revealed of the burden of other chronic diseases, not just that I said before. The most important reason for this, the high diseases and the lack of access to healthcare is the structural inequality. I just want to mention about this also topic, that the structural inequality also affects healthcare system. And there are lots of many factors that feed the health disparities for people of color. And for this situation, Dr. Khaldun, that I want to remind the formerly director of the health officer for the Detroit Department of Health. She defined as it's a contagious disease. It's interesting for me, and that's the bottom line. And people who have chronic conditions, asthma, diabetes, are more likely to get the diseases and then have more severe illnesses. Just for COVID-19 pandemic, she said. Also, we can define the structural inequalities that it includes differences in health, economic and social opportunities, so that the needs of minorities unable to meet these requirements. But to be honest, I couldn't find a good definition for or a comprehensive definition for structural inequality. So maybe Christy or Michael or anybody can define this topic well for us. Is it a good definition that just the differences in health, economic and social opportunities, so that the needs of minorities are unable to meet? Christine, how about your thought about this one?
So structural inequality is the phrase you're looking for?
I'm sorry?
Structural inequality is
Yes.
phrase, yeah. So, you know, inequality and equity, or inequity and inequality, are sort of different concepts. Disparities and structural disparities and structural vulnerabilities and structural inequality are also sort of different. But I think the point that we're, you know, we're in the pond where we're talking about different people get different things, and certain people are disadvantaged from having their piece of the pie. So equality would say, well, everybody gets the same thing. They get the same amount of the pie. Whereas equity would be more, you get what you need, you know? So if you need to be brought up to a certain level, you know, you're going to get more than somebody who doesn't have the same need. So, but they, you know, get at societal rules that disadvantage people for various reasons.
Can I speak to the structural part of this? Because I think that is also sort of a misunderstood concept. But when we say structural inequality or structural racism or structural whatever, what we mean is systematic, based in institutions, institutional policy, right? So it's not interpersonal. It's not even social determinants of health stuff. It's the systemic overlay of the way that we have organized our society in these different sectors and the policies that reinforce that systemic overlay, right? So,
so why would you take social determinants out of it?
It's larger than social determinants.
Yeah,
social determinants is embedded within it. So I think because it's a difference between race and racism. Mm-hmm. So racism is a structural issue. Race is a social determinant of health, which is problematic, but okay. Right? So there's a difference. It's a much larger issue. And Joanna, maybe, is she on the phone?
She left for a minute. I don't know if she came back.
Right, so there's, and we speak to this in the article too, in terms of the social medicine project, that, you know, that group is trying to look correctly, I think, at the structural determinants of health and not necessarily the social determinants of health, although they're interrelated. But I think that there's sort of a misunderstanding on what structural is, or what we mean by structural competency, a la Jonathan Metzl, and sort of that was one of the foundational, conceptual underpinnings of this portrait project. So structural inequality are the sort of the systemic institutional conditions that produce inequalities.
Thank you, Sandra, and thank you, Christy. And
I think, sorry, we have what? How many minutes left, Adrian?
I think I have about 20 left.
Yeah,
if I'm looking at it right.
I was about to interrupt Selchuk, but it's okay.
yeah.
If it's all right, we'll just move on to Laura, and then we can circle back afterwards just to give
okay, no problem.
Police brutality. Thank you.
Thank you.
Yeah, so Sandy, yeah, I should have about 20 minutes. So I'm trying to watch my clock over here. So hi everyone, and I'm talking about the third theme that we have, which is police brutality. And I have to say that it's been, it was really interesting. I think I went down many rabbit holes in this process, and I think learned a lot of things that I didn't recognize from a historical standpoint, maybe things that I knew, but didn't quite realize I knew, which may sound funny. And just excuse me for a minute while I bat my cat away. My cat is trying to come join us. No, so I think the things just to kind of give you a little bit of an introduction. So really in that narrative that we found and that, racism and this discrimination and bringing in the police aspect of it really kind of sheds a different lens to this health disparities and pandemic care. Looking back, thinking historically, and as I was looking through many of these articles, just looking at how historically there's been these pervasive, and I would say these structural systemic racist policies that have led to some, what I would say is unjust, unfair treatment of the Black community and of other communities as well. So looking back, and just to give a little overview, so really going quite a bit farther back. So the Africans were originally brought to America against their will as slaves. And then when they did that, they've kind of since that time have continued to suffer discrimination. So it's not been, and I like to think that when I learned history that we were making progress. And I'd like to think that a lot of times we've been making progress, but as I read more, learn more, become more aware, I'm not quite sure how much progress we've made. And so over the years, and just in particular, I will focus more from the 1950s on. So we'll look at that little section of history here. And just a definition, so police brutality, trying to find definitions, and some of these articles define them in different ways. But in the Journal of African American Studies, there was this article, and it defined it as the use of excessive physical force or verbal assault and psychological intimidation, which I think is a good way to capture it, because it goes beyond just the, oh, I shoved you, I hit you, it adds that aspect of that mental impact, that stressor impact that I think sometimes that, and again, this may be my own bias or my own lack of awareness, that I don't think as much about. And so I think that's really important to include that when you think about it. And looking at law violation and going back to kind of more that historical perspective, that people have arrested and imprisoned African American men and women and children in greater numbers than they have in other races. And there's a large overrepresentation of African Americans who are incarcerated. And in some of these articles, they are looking back at a historical standpoint, they originally said, oh, it's a biological thing. It's this intrinsic, this is how African Americans are. then there's been a change, kind of reading through some of this literature, that it's more cultural, and then it has transitioned to focusing on this, what they call African American criminality, which I think is a very interesting transition point. I'm not sure that that's better, but again, there's been that change. And some things I wanted to talk about specifically, and so in the 1950s, the Milwaukee Police Department employed the stop and question policies, and that really alienated those African American communities there. And the way it's described in the article, and this from this perspective, is that the African American communities, which may have been an assumption on those authors' points, I have to say, but they, you know, viewed it more as what I would liken to a military occupation of their home area, of their part of the city. So which said that basically if they have any question, they could come and just say, hey, I'm going to stop you, I'm going to question you. In the 1960s in New York, that was the stop and frisk policies, which I had heard of those, which allowed, and it authorized and allowed the police officers to stop, question, and search anyone who they thought had committed, was going to commit a crime. And so it really, they didn't have to have what I would think is very much in the way of just cause to stop them. I mean, if they had the least bit of a feeling, they could say, stop that person, and the police were authorized to do that. And then the other thing that was interesting is that in Chicago in the 1950s and 60s, Black police officers formed the Afro-American Patrolmen's League, which I thought was really interesting, to challenge police brutality against Black citizens, and they were prioritizing Black people over the police, which is kind of like kind of an internal movement, I think, there to counteract some of these. I mean, coming more closer to modern or more recent times, I guess in 1991, you think about Rodney King, and the Rodney King, he was beaten by the Los Angeles police officers, and I remember that on the news. I can remember that very clearly, watching the news reports of that. And in one of the articles, Cheney and Robertson examined the National Police Misconduct Statistics and Reporting Project, which I did not know existed, but this is a way that they report things that have happened about police brutality. And what I've learned is a lot of these databases are hard to come by, and they're not very accurate. So reporting of police brutality has been an issue, and how it's captured and how it's available so people can look at it. So during that time period from April of 2009 to June of 2010, they were looking at changes that occurred in police departments since the time of the Rodney King beating. So that was important. But they noted that there were almost 6,000 reports of misconduct, 382 fatalities related to misconduct, and like $347 million in settlements. 33% of the misconduct, which are the police misconduct cases, went to convictions. And so I think it was really interesting. So they're kind of looking at trying to examine it from a different light, trying to give I think a bit more of an objective approach to this. And again, there's in another article, which is Denise Hurd, Cycles of Threat, and that is the one that I would say I would list as a recommended article. It's in a law journal, and from the Boston University Law Review. And it was looking at a case and look kind of through the legal case Graham versus Connor, and looking at African American health inequities and police violence. And so it was very informative for me. But in that, they really looked at expanding the definition again of law enforcement violence to include physical, psychological, sexual violence, and neglect or failure to assist. And I think that's a key point as we think about the more recent events that have happened in the last few months, and that neglect or that failure to assist. So I would say keep that in mind. And when working on this, Sandy had mentioned about the Black Lives Matter. And so there is an article that is optional, so I think it's a resource if anybody's really interested in kind of getting the history of how it came into existence, that's available, and it's by Garrett Chase. And it's really, I think Black Lives Matter, I actually thought had been around a little bit longer than it has. But it really started the movement itself really was in 2014. So it's only been around for about 6 years. And it started to, in response to this case, George Zimmerman, who shot Trayvon Martin. And we've all heard about him in the media. And so it started originally as these, I would say very strong, strong females, very strong African-American females who were putting social media posts out there about this shooting. And Trayvon Martin, if anyone doesn't remember this case, he was visiting his father, and he African-American, and he's in this neighborhood, and this other gentleman, George Zimmerman, thought he was suspicious. He called the police. The police told him to stay in his car and not confront him, but he confronted him and shot and killed Trayvon Martin, who was 17 years old. So this Zimmerman was tried for second-degree murder. The verdict was not guilty, and there was much protesting that happened after this. Right about the same time in Ferguson, Missouri, there was another case. And so this is all really important to Black Lives Matter. Teenager Michael Brown was killed, and he was killed after an officer placed him in a chokehold. And again, I think it's really timely when we think about the more recent events that have happened. So they really started organizing, and Black Lives Matter is more of a grassroots effort. So there's not a designated leader. It's more the leadership by the members, and the members organize these movements. And those are some of the kind of historical things that bring us to where we are today. I think those are important. And to link this back, and I think now I want to link it back to our narrative, because I think there's some very strong things that are mentioned in this narrative about police brutality. And one of the things that I think is a really a discussion point for me, and I have it there, is talking about the lived experience of being an African-American man today. And I want to link this back to the narrative and read a little excerpt. Keith Gambrell described what he imagined that living while Black in the 1950s was like. I once wondered what it felt like for a Black person in the 1950s to have to step off the sidewalk when a white person walked by. It probably felt like it feels when you get pulled over and you have to keep your eyes looking a certain way. You can't make any sudden movements, even though your knees might be shaking, because they could kill you and get away with it. And just kind of want to open that up just as a starting point for the conversation.
Go ahead.
Me? Oh, okay. First of all, I just want to commend you for having this piece in the portrait. I was surprised when I saw it, and I thought it was really exciting to have this piece in the portrait, because I think that one of the important things that this conversation about police brutality does is it shifts the importance of how we look at racial disparities in health or anywhere else. It shifts the conversation from thinking about intent to thinking about outcomes, right? You know, I mean, this sort of thing, or these conversations suggest that intent is essentially tainted by all kinds of implicit and structural biases. And so what we need to do is look at the outcome. And in the first person narrative, his understanding, his equation of how to feel when you show up at a hospital and can't get treatment, tying that to how you feel when you're stopped in your car, was, I thought, very, very potent. And it really points to things that we don't look at and think about well, I don't, because I am, awash in privilege. But so, for example, we don't think about how many police officers are present all the time in the emergency department, right? We don't think about the fact that when you call an ambulance, the ambulance comes, but so does a police car. And we don't think about these things because you know, we may think, well, the police come so they can, you know, flash the lights and stop the traffic. But that may not be the way it's experienced by people who are not like me. So I think that that's a, first of all, this is a really important piece to be in the portrait altogether, but it also has great pedagogical opportunities for people to think about things that they just never imagined, never thought about.
Another way, Janet, that I would build on that is I would say both the police and healthcare have sort of an implicit social contract with society. And they're supposed to be there to serve and protect, to help, you know, people when they're acutely ill. I mean, the contract is broken or it doesn't include, you know, certain populations. And I think, again, knowing that the systems that are paid for, you know, whether it's through taxpayer dollars or whether it's for, you know, our employer benefits or Medicaid or whatever it is, it doesn't work for us if we're in certain categories.
Yeah, I want to echo what Janet was talking about. So there were two things that really tied in for me, this discussion of police brutality. So I was thinking about the assumptions that we make about patients when they show up for care, say at the emergency department, and likening this to assumptions that are made by the police around stop and question or stop and frisk. Right? And so that was one connection that was made in my mind of like, what are the assumptions that we were making when you stop and frisk or don't stop and don't frisk, right? Which is, you know, I suppose one way of thinking about what happened to Gary Fowler. The other image that really struck me in the narrative, in Gambrell's narrative, was running to his parents' house and seeing the ambulance there. And this was a case where the ambulance and the police were too late because the person was already dead. As opposed to, we can think about other narratives recently where that was not the case, but the outcome was absolutely the same for the individual.
There's a very interesting comparison point there. I like that.
I love that, Janet. I had not thought of that. That is like super important to make explicit, I think. Because I had not thought of that.
Yeah.
Yeah.
Yeah, I think that's very powerful. I think, like I said, when I start digging into this more, you start seeing things in ways, and I really appreciate what Janet said at first about just thinking about what it's like to, you know, coming to the hospital or having the police come with the ambulance to the house and the impact, and then really putting ourselves in another person's shoes in a different way than I think we normally do. And I don't think in medical education we do that often. I don't know that anyone I've ever really said, hey, you know, this is what it must be like, or imagine what it must be like for an ambulance to show up at your house with the police and the fire truck. You know, and my only experiences of that go back to when I was a kid with my grandparents. You know, I was at my grandparents' house and we called them in. But, you know, again, that's coming from a position of privilege and not from where that may be scary, intimidating, or have other ramifications or other feelings with it. So I think those are all wonderful points, and I appreciate that. The other thing that I think is interesting in the narrative, just in the interest of time, is they talk about linking it to, he links it to Breonna Taylor, George Floyd, and Ahmaud Arbery. And I think that's important as well, because there's that connection. I think we've been talking about these structural systemic things. And so, as you all know, I'm in Louisville. And so Breonna Taylor is here, that happened here. And we continue to have protests, and we had armed protests this weekend. And interestingly, there were the African-American group that came in, that was the armed militia that came in to protest peacefully, and one of them accidentally shot their gun off, and 3 people got shot during the protest because the one accidentally fired his gun. And, you know, they have these images on the news, and I don't know if they've made it to the national news, but they have this African-American militia that's protesting Breonna Taylor. And around the outside are these counter protests, which are these predominantly white armed protesters. And in the middle, you have the police. And I just think about that and linking that to how we've talked about structures and systems and how people are grouped together, and just, and I know I mentioned in one of the questions in the guide just about the role of the media. And so as I think about those strong images from what I saw in the news and thinking about that and what the media portrays. And I think for a discussion point, if we had more time, I would say, you know, really for people to think about focusing on a specific modality of media, whether it's social media, because that's where a lot of the younger people get their news from, or whether it's from, you know, in the older generation from the newspaper, because I know not many people that are younger are looking at the physical print newspapers, but just kind of focusing on how the media plays a role here. But again, everyone who is the viewer or the receiver of said media has a role as well. So we're all active participants. It's definitely not a passive thing. We all choose what we want to look at. I want to make sure in the interest of time that I bring up the other discussion topic. So, you know, the interesting thing is there was a case, and in the article, that Graham versus Connor. And I want to tell you a little bit about that case, because I think for me it was very impactful. And so this happened back in 1984. So this police officer in Charlotte stopped Mr. Graham for quote unquote unusual behavior after he was leaving a convenience store. And he was arrested for this acting suspicious with this unusual behavior. He wasn't armed, there was no crime committed, but they arrested him for the suspicious behavior. And he was trying to grab some orange juice, I believe, and to try to treat some hypoglycemic symptoms. And so he goes into police custody, he gets a broken foot, he gets some cuts, an injured shoulder. He ends up suing those five police officers in the city of Charlotte, and he lost. And the Supreme Court affirmed the use of police force, and let me get the wording right, allowed for police perceptions to be the standard for determining acceptable use of force against citizens. So it's the police officer who can make those judgments. And so there's much discussion about the criminalization of Black health issues, and I think that's an important thing. And you know, really, what is a crime? Is being hypoglycemic a crime? I mean, all of us would say, no, it's absolutely not a crime, but this is how the perception was in this case. And that was the concern. And the parallel, I think, here that I would want as a discussion point is talking about the war on drugs. And because the war on drugs really focused on cocaine and crack cocaine, and it was much more common in the African American communities, and they really, in the way that society, those structural things that addressed it was by criminalizing it and policing it. Now I think about the opioid pandemic or epidemic today, and you look at that, and our approach is much different. We try to do more of a medical approach to it, right? We want to give people treatment. People do get arrested, but it's not as prevalent. There's not as much push to say, hey, you're abusing your oxycodone, we need to arrest you. So I think there's a big difference there, and I think that's very powerful as a discussion point to think about that criminalization of some health matters. And I will say that, again, that's something that has not been taught to me before, and so I found that very powerful. So any thoughts here in the last about 5 minutes before we take a break?
So the criminalization of crack cocaine in the 80s by the Reagan administration, because the war on drugs starts with Nixon, but then it shifts to this it's all criminalization, but it really starts to gain hold in the Reagan era. But what was I going to say? Forgot what I was going to say.
Well, real quick on that too. In the Reagan, I mean, that was the Iran-Contra scandal. The U.S. government introduced rock cocaine into the ghettos.
Oh, yes, absolutely. That's
that
right.
wasn't a natural occurring drug.
No, right. Just like the opioid crisis is not a natural occurring problem either, is a deliberate pharmaceutical company push. But what I was going to say is that it leads to incarceration, right? The criminalization leads to incarceration. It leads to the breakup of families. So first it's African-American men, and then, it's the breakup of their family with the women, and then the women end up going to jail, and then you have a bunch of children in foster care. So it has all these cascading events that occur. And from that incarceration, then you have Clinton, deepening the incarceration and criminalization by the Clinton years. And now we have this, massive problem with incarceration. And so it sort of is an interesting tie-in to everything that we've been talking about, from housing to access and inequality to brutality. Yeah, Janet.
Yeah, I think that the criminalization aspect is mirrored in a way by sort of the structuralized, structural notion of deservingness also, right? Because criminalization happens because certain people must be protected. Their safety must be protected. Those people, of course, are white people, affluent people who have property deserving of protection. And so this notion of deservingness fuels how communities are policed. It fuels how communities' housing is structured. It fuels the notion of who gets treatment at an emergency center. So I would say that, they're sort of balancing mirror images.
And I think it's really important in today's discourses around protests, right? And the destruction of property and the protection of property, but only certain property in certain locales, right? And yeah. I keep thinking also, Laura, what you were saying about the media and sort of the effect, this shift to cameras, police wearing cameras, I think is really important. I don't know if people have been studying that. Michael, you might. Sort of the filming of it, not only by citizens, but by the police force itself, and how that has changed our landscape of what we know is going on with police brutality, but then also Black Lives Matter and female. I loved how you brought up the history of Black Lives Matter movement, starting from, my timer is going off for us. So yeah, how women, and we're seeing this too, like how women, started Black Lives Matter, how these, I don't know if we would know about George Floyd without Black Lives Matter. And how that then led to all these other protests, but then how, the moms in Portland is also a female-led protest about a different matter, but still, it's sort of, I think it's within that context of Black Lives Matter. In some ways, I feel like it's inspired by Black Lives Matter. I don't know if that's true, but
one real quick thing too about the criminality of the Black body, and therefore any kind of health issue. If you even go back to the story, the first person narrative, and Janet, you drew our attention to, if a Black person gets pulled over, they have to make sure they're sitting still, even if their leg itches or hurts, right? Because any movement is criminal, right? Even though it's a bodily ache that they're responding to, right? I mean, so it's like, even there's a way in which that story can be brought down to just such a perfect example of just movement is criminal.
I think that's a great point. Just as we wrap up, I wanted to say one thing to kind of link this all back to health disparities. So we've talked about these systemic structural issues, but the other thing that's mentioned in a lot of these articles is the effect of chronic stress and how that really impacts chronic disease in these populations where they experience this chronic stress, whether it's because they're near the police violence, they experience it themselves, they're around shootings, but all of that can further amplify things, medical issues that are pre-existing because they're under a lot of chronic stress, and then they don't have the access to healthcare and they have other limitations. And so it's this horrible, vicious cycle of structural things and systemic things that are there that really kind of keep this perpetuating the same cycle that we're seeing. And so I think that that's been the most powerful thing I learned in all of this, is just how much it's linked together and how it's so much bigger, and just the structural thing. Sandy?
Yeah, and I want to just quickly connect this to the other article that you required on structural racism, and it's the Nancy Krieger article. Nancy Krieger is one of my idols. And you know, social epidemiology, this is the crux of social epidemiology, is to understand how things like racism then sort of find themselves in the body, right? And reveal themselves in and through the body, and in and through patterns of disease, right? So I love that article. Of course I'm going to love that article. It's Nancy Krieger. But yeah, I think that your last point really speaks to that article. And it's really a very important one.
All right, well, thank you. I think this is a good time for us to take a little break, and then we can come back and discuss part 2. So how long do you think, Sandy? 10 minutes, you think, or?
Yeah, maximum. Yeah, 10 minutes.
Okay.
Is that
Sounds
okay,
good.
everyone?
See you back in a little bit.
I want to ask you guys at the way end if you can just speak for 2 minutes maybe about what you learned through this process, or if it was a positive process for you, or if like you thought it was a waste of time.
Are you talking about the portraits process, Sandy?
Yeah, the building of the portrait process. Hi, Joanna.
Hi, I'm so sorry. It was an Office of Access and Equity student concern. It was really kind of urgent, so I apologize.
No problem.
Sorry to miss some of the time.
Glad you came back. That's all that matters.
I know it's like it becomes, we create this, there's something of this collective experience, and so I hated to have to step away from fully taking on the experience, but.
Okay. Where's Christy's back or not? Not yet. I think we should probably start because just hoping she comes back quickly because we're running out of time. So I want to make sure that we have some time for this. This is an important part of the workshop.
Was there a particular place, Sandy, you wanted us to start in terms of the pedagogical piece, or?
I think we should follow what you have in the teaching guide.
Okay.
For the most part, yeah.
Okay. So I think in the second part, it's sort of a pedagogical discussion, but as we understood it too, I think it was an opportunity for all of you to give us suggestions too on the portrait. But this was to guide people who wanted to take what we have in the portrait and bring it to their own settings. And so in the first part, we have a question for instructors. How would you adapt the current portrait if you had limited time or resources? Because as we know, a lot of curricula are overstuffed and there's not a lot of time. Are there other adaptations that need to be made in the context in which you plan to teach this? And I think it's the same question in terms of the learning objectives in question 2. How would you need to adapt the learning objectives to the learners, depending on the health profession, level of training, context, et cetera? And we had discussed this with Sandy too, because I think in the original portraits that we saw, it said medical student classroom, but we didn't, I think the intent was, for all health professional learners to be able to take this in whatever context there was. And so here were a few questions we had to consider: the historical and current impact of race in accessing and receiving medical care. So akin to what Selchuk was talking about, the historical understanding of racial disparities in accessing and receiving medical care in the current context of COVID-19, which is quite topical. Identifying social and structural factors that intersect with race and influence the health of racialized communities, and to examine the relationship between racialized communities and the police in illuminating structural racism. So all those sort of different lenses and components that we had. I don't know if there are any comments, anything anyone would suggest there? We're good?
No, I think that.
Yeah, good. Oh, Sandy, we're good. Yeah.
I guess just to the first point, I mean, first of all, I just want to say that I love how multifaceted this was and how you really brought up so many very important critical aspects to consider. I guess the one thing for me was when it was like a historical piece about pandemics, I didn't see a piece. I guess I was expecting a piece that spoke to how these things were addressed in past pandemics and how could we learn from pandemics in the past and what the outcomes were. And I was I felt that part was missing. I didn't see as much of that historical lens. So I was kind of, in the context of a pandemic, how does racism play out? How did we see that play out? Are there analyses that have been made from past pandemics that we can now bring into this current one and learn from? So I felt, unless I missed something, I felt like that was something that I was expecting more to see in the context of past pandemics.
And then also, I think an example of how rich that story was on its surface, it seems pretty straightforward, right? That it just provides a narrative. But if you spend time with it and apply pressure, so to speak, and what Janet was, initiated that turn when we were moving deeper into it, it really blows up. And I think a way to, if you want those three main areas that you're focused on, is that you bring the learners back to the story and show them where it's happening. Because they're going to initially read it one way, probably on the surface, right? But then if you take them through how to read it slowly and what's going on in these different scenes, you can then say, then you can pull back and point to the housing issues. You can point to the police brutality, right? And you're anchoring it every time to that first person account.
Fair enough, because I realized we're into part 3 of our guide, right? Which is, I should have read out, was refining our portrait.
I'm sorry, yes.
No, that's okay. No, exactly. I invited commentary on it, so I just didn't get to that.
I always jump ahead. Yes.
No, you were anticipating it, which is, was there anything you would modify? Any other readers with any other readings? And I think Joanna suggested the historical one on race and pandemics in the past, and any other issues within the larger social theme that were excluded or require further exploration. Because one of the thoughts I had was the order in which we explored it. I wonder if we should have done like accessing medical care first, put in that second narrative, right, with the zip codes, then do housing, because then it explicitly lists the housing, and then do police brutality, because it rounds out the entire piece and it links better to the narrative, which starts with the access piece, right? Refers to a past episode of what happened in that earlier Detroit Free Press article in April, which I think we should include, and then come back to the police brutality piece and see how all of these sort of different layers of structural racism get played out. Because it does what I think, was part of what Sandy wanted us to speak to, was our experience of doing this, which was to take, I think, I also really like that Lancet paper that we assigned, because it really made me think about how in medical education, we thought a lot about the interpersonal racism piece and cultural competency, but we never really were explicitly given the opportunity to reflect on or to seriously consider structural aspects. And this really forced us to do that, to say beyond that interaction. I know Janet wants to say something too, right? What's the bigger piece? So Janet's next, sorry.
No. I apologize very much, Adrienne. It just seemed like from your pace of speech that you had gotten to a period.
Yeah, sorry.
No, it's okay. I just don't know you well enough to know when to jump in or not. So I'm just going to be, I'm going to make one comment, which is just my pedagogical nitpickiness.
Yeah.
Okay, which is your first learning objective. The verb is consider. Yeah. And if I'm a real geek about behavioral learning objectives, I can't observe consider. And so I would encourage you to use a verb like discuss, describe, something like that, because those are observable things. I can see somebody doing that, right? The rest of them, I don't have a problem with. Now, I want to get back to the really bigger question that you're asking in question 1, which is what do you do with this case or this process given an already time-pressured curriculum? And I thought it was really interesting. So this is just my initial reaction to the word portrait. And so I'm imagining myself in an art gallery, right? And then of course I got your instructional materials and I was like, oh, that's the kind of portrait you mean. Not exactly the same thing. And yet, if I use that as kind of an analogy, then it seems to me like it's possible to, for a smaller number of people to create portraits, to create materials, who then provide a narrative. And, I can think about that in the form of, say, something very popular now with a podcast, and so that allows me, the learner, to participate on different levels. Is I can listen to a relatively shorter description of the portrait. I can read the portrait and the analysis. I can read the articles, or I can dive even deeper into some of these supplementary materials, right? And then I might go a step further, which is I think what you really want people to do, which is to start constructing portraits themselves as they see relevant issues, where perhaps that person then needs a little bit of training in history, in reading narrative, in sociology, or perhaps a number of other disciplines. I'm just doing a scattershot there. And so I think having multiple ways of engaging with these portraits is the way that you fit it into a crowded curriculum. It's a create your own adventure. You know, you pick the level of depth that you want to do. That's my story, and I'm sticking with it.
I really like that. I mean, the way that we did it in the NEH grant was to ask the creator to sort of frame the whole thing, either with a small PowerPoint or a recording of themselves just talking about it. I don't think we've been so successful in getting people to actually do that, right, Michael? But I do like the podcast idea, and maybe thinking about it in terms of like a part of the portrait, like an integral part of the portrait development. So that's I really like that. And I like how you've thought about the different ways of engaging. I think that's really great. Wonderful. Thank you. That's very helpful.
Looks like, I feel like other Janet.
Yeah. So just to,
we're not other, it's just Janet or Janet.
Janet.
Neither of us is other.
oh, I think I'm always other, but that's another matter. Anyway, thinking also of what Janet had already said about finding different ways, different materials for people to engage in a different way, and about the difficulty of finding first-person narratives on this very new, well, 5 months old, 6 months old, so it's not that new, but other ways of finding first-person narratives that might, you know, if you're thinking of a podcast, you could intersperse different forms of first-person narratives with different issues that you want to foreground. If you want to foreground housing in one, and others, you might look at poetry, at poetry or flash fiction. These are things that are just coming out in publication now. But there would be materials to use there that aren't necessarily journalistic first-person narratives, but that could give you that same way of drawing you into someone's story.
And if I can play up, go ahead, Christy.
I was just going to say, I think that there are structural issues in terms of being able to tell your narrative. And I think that's part of the discussion here, is talking about why are these voices silent? Why aren't we hearing, you know, the stories of people? Just having access to places which are interested in hearing your story or publishing. You know, there are health literacy issues and educational issues. There are time pressures. I mean, there are quite simply just issues that make some people's stories more accessible and prominent than others. And that's part of the problem. You know, we've known for years that people who are in nursing homes are invisible in terms of their voices. You know, you don't go in there, you don't ask people about their, you know, satisfaction with care. I mean, the fact that COVID and long-term care is at least being documented right now is actually a step forward. My guess is, by the way, with the historical issues of pandemics, my guess is this is probably the first pandemic where we've required collection of demographic data that's actually being analyzed. And it's still very imperfect and limited, but I'd be curious if we got into it to see whether we have pandemic analyses from the standpoint of demographic variables. I did want to say to you all.
Well, can I jump in? I mean, the John Snow example is the perfect one in terms of housing and demographics, right? Because that's how he figured it out. So you could use John Snow.
So the one thing I did want to say is I really love the topics that you all chose to use with COVID because they were atypical. And I think that, you know, people say, oh, what does police violence have to do with COVID? And what does housing have to do with COVID? Made that very powerful for me. And I think when I look at the amount of time and how much your learners would get out of this, it was very well done.
I just want to reiterate, I agree with her, with Christine. I also really like the idea that you have of reordering it where it's access first and then it kind of unfolds into these other issues, because that is a clear connect with the narrative, but then these other things that like you're saying are layers that intersect and affect people's lives but aren't directly explicitly stated. I really think that would make a more natural evolution of how these things are connected. The other comment I want to make, and this is something that we're coming across with trying to roll these out, and I don't know if you want to get into this or not, but if you thought about what happens, a lot of issues we're having with trying to roll these out in classrooms, regardless of trying to bring it to nursing and other health professions, is that most of their learning is going to be asynchronous. So like nurses almost are never actually taking synchronous classes, and so, or synchronous. So I'm wondering, I don't know if we want to discuss that here, but you know, we talked about the idea that these portraits come alive in the context of a discussion, and can you do this portrait and adapt it in our online environment if students are not expected to all be showing up at a particular time to actually have a live discussion?
I was actually thinking about that too. I was thinking about a paper that I really like by Arno Kumagai about the difference between dialogue and discussion, and thinking about why this was different for us to do coming from a medical background. Like in medicine, we were like all about discussion. We want like a diagnosis. We want to get to a destination. We were talking about, Laura and I were talking about that yesterday, like get to the chase, what is it? And if we don't know, what else do we need to know to know it, right? Or else it's like idiopathic or something like that, or NYD. But this was about dialogue. This was about exploration, about opening up spaces, and that and having a space for that. Right. And I think vulnerability too in the dialogue. And so I agree with you that when you do, like, because you think about the sort of the learning environment and what you need to create to be vulnerable, to be able to discuss these, like to have a dialogue, like an honest, open dialogue about these sorts of things. And I don't know that you can do that asynchronously. And my worry is that, like, say you try to do it on social media or some way, right? Like a Twitter group, is people start to tweet things out and it's just, you know what I mean? There's something like even doing this sort of face-to-face on Zoom is still different than if the immediacy, if we were all in a room together. Like there's something different and we're trying to approximate it. And these are really deep issues, right? They're deep societal issues. Because the other thing I was reflective of is we're talking about racism in COVID in sort of like African-American, Latino, and then we talk about sort of the Native American population. But being Asian, I think about the number of times President Trump says China virus. Right? And to the things that my other Asian friends are posting about racism against Asians, because people believe that somehow if you were Asian, you caused the virus, right? And that was very interesting, right? Because there's all of these different things that are happening. Like in Canada, we always like to think that maybe we are not so touched by it, but we actually are. So you'll see reports from, say, Vancouver in British Columbia, where there's a big sort of Asian population. And there are really overt acts of violence, like people getting assaulted, Asian people getting assaulted, getting yelled at, all sorts of horrible things are happening. And it's a very interesting like moment, right? To think about. When I was thinking about like other Janet, I didn't other in that way, but there is a kind of othering of people in this, right? Like us versus them. and not a sense of the global piece of this, right? Like even when we in the history session that we did with Sandy earlier, we were talking about the great pandemic of 1918, which is called the Spanish flu, which is such a misnomer because you'd think about it as something originated in Spain, but there were cases outside of Spain before then, and even in fact in America earlier, right? But
it originated in Kansas, remember, Adrian?
Yeah, yes, in Kansas. Yes, I wasn't going to say Kansas. I was going to say America as the bigger. But I was going to not point out people from Kansas. But anyways, yeah, it originated there first. But so people, when they talk about the Spanish flu, they think, oh, it was the Spaniards who had the difficulty, right? And in the way that when you call it like the Wuhan virus, that's why I think the WHO was like, let's not call it anything about, a racial, ethnic, or country origin, right? But so we have like COVID-19, but you can see the narrative because and the evolving piece of that information. So it's interesting because I imagine this portrait will evolve over time. That was my big thing about the dialogue, that it will evolve as more comes out of it. But it's sort of a starting off point to talk about it, as we're also focused in medicine right now on like PPE and treating patients. There's a bigger picture happening here. And I think it would be really interesting to bring it into medical school and other health profession schools curricula, just to see where it goes, right? That's really interesting. But I don't know if any of the other members of the group have any sort of reflections on this and on the sort of the curriculum and what we designed.
I think one of the like hard parts about what we tried to do is we chose like a very broad topic, and in order to kind of like build, and we chose a we wanted to analyze things through kind of a historical lens, but to do that, there's just so much factual knowledge that needs to be like transferred before you can even have a discussion. I found it like hard to balance like, okay, these are the points that these are the points that are foundational to be able to have an actual conversation. So there's a lot of work that is on like required of the learners to like learn a lot and then to incorporate and then discuss it. So sometimes I was just wondering if it was going to be overwhelming for the learners just because there's so much that has to go into it. And we're taking a different lens and a whole different kind of like mode of teaching, which medical students aren't used to learning through. So I guess I was a little worried that this might just be too hard of an exercise for some or most.
Well, I think one thing too, I think who's going to be most overwhelmed by it is who's ever trying to lead it, because I can almost guarantee you that they're going to look out at the Brady Bunch screen and no one's going to have anything to say because students will not have read it. I mean, you just cannot count on students doing any reading before this. I mean, that's just a fact. Maybe you can at why, education, but I just don't see it. That's always the problem, right? And so my point earlier is that I think you have a very good first-person narrative, and I would also suggest moving into the blogs and such, and get away from official publications, right? Because they're not going to recognize voices that I think would be most important here right now. And so maybe something with blogs, but if always tying it back, this is me that is the literary person, but always tying it back to the story is going to be the way to do it. And you could even introduce some of the ideas you have around those three levels. You could do paragraphs that you read together. You know what I'm saying? I mean, it's just, there's nothing.
Yeah, Michael.
There's nothing more soul killing than you coming in and being so stoked about your session and no one's read.
And that happens all the time to us.
Yeah, if your session rests on it, it's gonna crash and burn.
So I also want to second what Michael is saying. I think bringing it back to the narrative, but also does the sort of thing that we're trying to do, which is to tie the narrative to the scholarly pieces and not have them be separate. So by continually going in that cycle, you fulfill that goal. But I also would say, like the housing article, for example, if you're going to continue to use it and assign it, just take excerpts. It's true, like definitely no medical student or health profession student is going to read it. I liked it, but I mean, you know, they're not going to read it. So you can take excerpts. Same with, and when you take excerpts, you can also sort of have more excerpts from the police brutality or the access to care, so that it's not just only the housing stuff that people are reading, but little, let's say, snippets. I will say they did, Michael, they did try to look at blogs and a whole bunch of other things. I'm not sure if you guys looked at poetry, but, you know, this desperation to find a narrative, they looked at everything. I mean, at least I think I told them to look at everything, YouTube and whatever, right, Adrienne?
We found a lot, like we were going to go HIV because we couldn't find another pandemic. We were like, we can't do this for COVID. And you know what it reminded me of is when, you know, for school-age children, things went virtual. But it was not equitable because those who could afford, who had internet and who had computers, and for their families, they could access the online. And if you were in a better like neighborhood in terms of your school board or whatever, but that we were looking online. And I was just thinking, for all the people who are really suffering, who is blogging or writing poetry right now if you're trying to survive this, right? Like maybe someone is, but I guess I couldn't think of it. Like maybe they just didn't even have access to the ways to get your story out. And I was thinking about that. I don't know what I was watching something on media and diversity in media and who tells stories in media and how it isn't so diverse about who is in media and who tells those stories. So I wondered whether it was we wondered if it was part of that too, but we were getting, I don't know, I won't speak for the whole group, but I think we were almost ready. Like we were at our wits' end.
I will say it was really difficult. I mean, I was hopeful. I'm a geriatrician. Like I said, I practice in nursing homes and have lived through a pandemic, you know, an outbreak in my facility, and there had to be something, but there was nothing. I mean, I was very disappointed in the lack of first person narratives, just trying to find, you know, anything about this. And we were looking at blogs, and I was looking at some international kind of blogish things, but they didn't really address what we wanted. I mean, we went, it was very challenging. I think that we were all shocked at the level of difficulty to actually find something. And this one worked, and it has a lot of depth, and I think I really like that. But it was not what we were, I think, originally looking for and hoping to find.
I mean, I'm wondering though too, is the treatment of African Americans any different during the pandemic than it is business as usual? Do you know what I'm saying? And so far as, I mean, maybe this has made it more condensed.
Yeah.
Right? But is it really all that different? Take away the pandemic and they're still, you know, getting screwed at the hospitals, right? They're not getting the care they need. So I'm just wondering if the focus on the pandemic in some ways puts it at the forefront when it really shouldn't be. What should be at the forefront is the way in which structural racism prevents them from getting care.
If I may,
Janet.
I'd like to follow up on what Michael has just said, but I'm going to present it in a more, perhaps more cynical perspective. So confessing to all of you, when I first read the narrative and read about the patient being denied care, I thought, I did what I think probably a lot of physicians might do, which is blame the patient, right? Which is, how can that possibly be true? What did he or didn't he say clearly that would have gotten people's attention, right? And so I think the reason I'm divulging this is to say, boy, to start off with this idea of access, I think is the hook, because I think depending upon the levels of learners that this portrait might be used with, I think there might be some concerns about that, of it's his problem, not my problem, of how he presented himself and what he said was the particular situation. And then maybe there is that link to, as Michael is saying, how's this different than business as usual? You know, if a person doesn't look like me. And so maybe that's a place to go with this. It's not just the pandemic.
Well, it was something that I thought was interesting when Michael talked about why is it that we're looking at this in particular? Is it really different? And then it was sort of reinforced by what Janet said, was that I remember there being at the, early on in the pandemic, there were instructions to people: don't come to the hospital. Do not come yourself to the hospital. You call 911 and you tell them that you think you have COVID-19. And, thinking about this story made me think about those instructions being themselves sort of a plank in the structural violence done to people, right? It was institutionalizing the ways in which you can access medical care being unequal and demanding of the patient that you tell people already what the conclusion is. I mean, it was in itself a way of looking at the intersections between race and medical access to care.
Yeah, I hope that we never were kind of communicating that we thought this was a different, unique situation, but more that it like highlighted or exacerbated kind of underlying conditions in America. And I think that's like, it was interesting because it's topical, but it also does a good job of really kind of raising questions of, I mean, for mine, it was like housing. Why is housing relevant to health? There's a pretty like obvious tie here that is, yeah, I think it's nicely highlighted by this particular pandemic. And that's why we kind of chose to use it as a frame for everything else.
Well, the reason I brought it up was not because I didn't think it's worthwhile at all. It was just that you might then have access to a lot more, maybe, first-person narratives, right? If you don't have to have it linked to the pandemic. That's all I'm saying.
Well, I think also that, I think that it's the reason why you chose history as opposed to another discipline, humanities discipline, to explore it, because it's not really that different, right, than other disparities of health, except it's in this, very unusual historical moment. But by foregrounding history as the sort of way in, that I think is trying to make that point, right? But I do think what Michael's bringing up, which is an important point, which is to ask that question explicitly. So here we have this narrative. I think we can all agree that the narrative should stay in the revised, finalized portrait. So if that is the case, you can say, like, here we have this narrative. Okay, so what is different about this than any other time? Is the pandemic just highlighting and revealing these already established kind of foundational patterns, or revealing the fault lines, as Seljuk said? Or is it in a particular, just make it explicit and ask it as a discussion question. I think it's a really interesting discussion question.
I love the narrative, and I don't actually think you need any other narratives, because the other thing this does that is really powerful is talk about Black Lives Matter and COVID. And there's no coincidence that these are happening at the same moment in time. And that narrative is the perfect narrative to be able to do that and to go where you ended up going. So that's my feeling. I just think it worked beautifully.
Yay, Adrian.
It's like dumb luck. Like you Google enough.
She's like, what about this one? What about this one? Okay, listen, we are at our wit's end. How about this one?
Well, because we were going to go with the AIDS one, but you're like, no, that's too long. I was like, I don't know. But I was just wondering about the time. Where are we? I've lost track. Are we at time?
Yeah, we're at 3:30 Central.
Yeah.
So I don't know what people's time span is, but if you could just speak, are there any outstanding questions or issues that people think, the audience thinks these students need to do for their revised? Like, is there another reading that should replace this? Can you think of other readings, even though Michael says no one's going to read anything? I still think we need some readings. Other things that should they read the history of Black Lives Matter or the legal pieces of the excerpts from the legal thing instead of the housing one? I mean, these things are, what's so cool is that you can interchange and.
I have this is a purely hypothetical suggestion. I don't know if it exists. I thought that the housing piece was really good, but also really challenging. Just challenging to get through, challenging to find your way in. It was long, too. And I'm just wondering if there is. I remember hearing, on NPR in the morning, a story about ambulances refusing to go into certain neighborhoods during COVID-19. And I wonder if something like that would sort of it would be a narrative thing, but it would also invite people into considering the way zip code affects treatment in this and access to care in the COVID-19 context. Unfortunately, it wouldn't be a historical approach though. So it's missing that piece entirely.
I'm going to go with the idea that you just excerpt a few pages from the reading. I don't think they need to read it all. And I think that if they got interested, some people might choose to, some might not. I'm still struggling with where these portraits belong. And I'm settling in my mind on the fact that these are more advanced students. They're not first years. I think that students in their clerkship years are going to be much more interested and open in exploring, these kind of issues because they're seeing it. They know that they're having, patients who aren't getting their needs met and they can't quite figure out what those problems are. One thing I'm wondering is there a way to get the students more engaged in actually teaching each other the portraits? Could you envision doing this over lunch hour over 2 days, for instance? Assign, different students to have to lead the discussion about different aspects of it.
You mean taking already established portraits?
Well, like say,
just having them teach.
He took the housing and he distilled it, and so rather than having every student reading everything, you could sort of, provide the narrative that everybody has to read, and then distill some of these other materials and have them presented by a student to the rest of the group. So if you had like a lunch and portrait, series, and you did it, for an hour and you did it over 2 days, I don't know. I just wonder if that would work. Because I think that the clinical student is the right level of training, or above to tackle these.
One thing this is a slight departure or a radical departure from that, but Adrian, it's very interesting. When you began the whole session, you drew attention to how this portrait is about ways of knowing so different from our medical training. And then when we went into the meta section, part 2, you started with that again. That was how you started. And so I think that's something to pay attention to, right? Is that I would imagine what you're talking about is a kind of resistance at first, right? You're like, get to the chase, what's the point? And so I think that has to be how you imagine this and structure it, is that's going to be, and I think it's going to be the same with students in their clinical rotations. They're going to be like, get cut to the chase, right? And so how do you, because this isn't necessarily about doing, right? It's about a way of thinking and seeing. So like in the story, how we kept seeing different things going on there, the more attention we paid to it, right? So I think what this is about is getting students and healthcare providers to see bigger pictures. But it's not about action necessarily right away. It could lead to action later on in terms of larger changes within the hospital, say, or a practice. But I think it's important because you punctuate, you started each one, Ingrid, with that comment, and I'm assuming the rest of your team feels the same way, right? And so keep that in mind, that's going to be what they're going to want also.
Yeah, I think you're.
And we speak to this.
Yeah. Oh, sorry, just about motivation, right? Of what motivates people to learn or to participate in things, and you always think that you don't want to be too cynical about it, but that a lot of it, especially at the undergraduate level, but even at the graduate level, is about assessment. That assessment drives the learning. Like, is this going to be on a test? Is this something that, while I need, like, you can actually, appeal to someone's better angels, right? And say, this is a bigger picture about the place we have in society and the responsibility we have and the part we play. But I think sometimes it's harder to see that bigger picture, be interested in it when you're preoccupied with other aspects. That's just not speaking for everyone else, but my own thought, if I thought back to my medical school self and think about the medical students that I teach now, that, some of them will want to have that discussion with you, but then they'll be like, is it on the exam? Right.
Yeah, that's right. And we actually speak to that in our article explicitly, like the thinking is the doing. We're not trying to figure out a new policy or management plan, or that's not what this is. This is about the thinking. The thinking is the action. The dialogue is the action, right?
You're cultivating empathic curiosity with that thinking.
Yes, and that's in the article. Yes, that's one of it. One of the things that we're trying to do, yes. So we call it something, oh God, Joanna, you're gonna have to remind me what we call it, or Michael. We use Jody, but we don't call it empathic curiosity, we call it something curiosity. But in any case, I should know this. What was I gonna say? I'm sorry.
I wonder if this segues nicely to the reflection you wanted us to do, Sandy, like each of us had 2 minutes on what we did, and then just and
then conclude,
One
more thing. So Joanna, when Joanna taught one of the portraits and tested it or piloted it, a big discussion that came up afterwards, and the feedback was, we cannot do this right now because we're about to take our test or our boards, right? And it was huge. It was like there was a lot of resistance to doing this kind of work before they came in and actually experienced it, because they have the boards and they needed to study. So you're right. It is definitely an issue. And maybe Joanna, you want to quickly say something, and then you guys.
I think it seems like from the beginning of summer, whether they're supposed to be studying for STEP or not, and you guys know this more than I, because I was not a medical student, they're starting from the get-go of M2 year. And so it wasn't even right before when they're supposed to be dedicated. It was literally get this in really, really early in M2 year, or again, it just reiterates exactly what you're saying. Is this going to be on the test? No, I'm tuning out. Also, if you're making me come to this and it doesn't have to do a step, I'm going to resent it, or I'm not going to read it, or whatever. So I think it was, the timing was really critical for medical students. They all agreed this was really, really important content. They thought everybody should have access to it, any kind of student, and that the approach was really important, a different lens and a different way of looking and exploring healthcare. But the timing was a big issue for them that didn't necessarily identify. I think we need to put that out to others like Christy, who's really intimately involved in where things are placed in the curriculum and things like that.
Yeah, I mean, in a
So
sense,
do you guys?
in a sense, this is like kind of a radical like activity in the setting of med school. Like everyone's in the culture of medicine is you need to get a number on your step, and there's all just like numbers and pure empiricism, and that's led to badness that we want to, I think collectively want to overhaul. But like going up against that kind of takes, it's hard for just one class to kind of overcome all of those barriers. So I get that it'd be hard. I just wouldn't be too cynical about like, well, we didn't change everything all at once in one thing. Like once I get enough power, I'll try to take some power away from the steps, and then this will be easier. But I think it's just like it's going to be a very, very, very long process with a lot of different steps in it. And I think the one, I guess back to Sandy's initial question, like takeaways from this, teaching complicated, like intersectional topics is incredibly hard. And we tried to distill like what people, like many people have written many books and theses about into an hour. And I feel like I was just overwhelmed trying to do that. But I mean, I think it was a good practice in like attempting to unpack some of these things in a way that's coherent for learners.
I think that's really helpful for you guys to share the experience that you had creating this. I know it was like, you know, I like that it was challenging, but even in ways that you think I mean, we all, most of us on this call actually developed our own as well. And we were like pulling our hair out, and it was extremely more time consuming than we expected. Do you think there needs to be any more guidance or anything that would help students? I mean, again, it's very nuanced to the topic itself, but do you feel that you needed any more guidance in terms of how to find, or like, and I know that Sandy was probably like had your back the entire time, but in the event that that's not available, you know, do you feel like there was any other guidance that would have helped you facilitate the process in any way?
And I think one of the things I mean, I'm sure there was some clarification at some point and I just forgot it, but how focused our discussion should be. Like, should I really like specifically guide the conversation one way, or just kind of propose topics and see what happens? And then I guess tied to that is like the level of detail to which like I want to discuss the specifics of the historical papers. But it feels like there's no real way to it feels like it's just like you got to do it and see what happens almost.
I mean, I would just say that I think Michael, because I also witnessed how Michael, you know, did this, and someone that this is what his expertise is. And I think that like returning to the text and bringing people back, because there was a tendency to really extrapolate, or, you know, at first I thought, oh, this is great, we're going to talk about our personal things. And it was like, this is not really so much about that. It's really about the text, and it's about going back there. And so I think that kind of like pulling people back to where we want to go is a really helpful approach, because it is very easy to get on tangents. And I think that's one people back.
And I think you can go back with, you know, the empiricism thing, the tyranny of empiricism, right? Is that you have all kinds of evidence in the story, and you're just asking your students to keep looking at the same piece of evidence for all that it contains, right? So it is in some ways a clinical act, if you will.
Or what it doesn't say sometimes too, what's left out, or.
Yeah, exactly.
We talked a little bit about having the companion article as an activity. Oh, we didn't get to talk about that in the second half. Well, this is the second half. But, you know, like sort of handing that out or showing it on a screen or whatever, and using that as an activity as additional evidence. And so what happens when you have additional evidence enter into the conversation after you made all these assumptions of the silences in the first person narrative, and then the companion, not fully but somewhat, fills some of those gaps. And so, you know, again, like the levels of evidence, different kinds of evidence, how you triangulate that evidence, and using that as an activity.
I don't know, Selchuk, did you want to go to talk about your experiences, your reflections?
Yes, especially for companion activities, we also think the additional additional article about this about this I'm sorry, I couldn't find, but we just think about that this article can be an companion activities to think on it and integrate the first narrative, the informations of the second one, and we can integrate with the first one to companion. But I'm not sure if we achieved our goals yet. Maybe we need additional aspects or additional sources for this kind of activities, as Sandy talked about. And I think the most important and maybe difficult part of managing the process is to return the first narrative. When we talk about our topics or the sub-themes, yes, we need to return the topics, return the first narratives, but I think it's the most difficult aspect of management of the process. So how we can manage this process, I'm not sure. Maybe it's just similar with close reading, I think. Michael, I'm not sure, but do you have any advice for us to manage this process?
Well, no, I mean, I think I was what I'm saying. I mean, I basically said what I think is important about, just keep going back to the text. I just want to be mindful about the time, because I don't know what other people have going on here. I mean, so I can keep talking, but I think that let's maybe.
I think we need to wrap. Sorry, I need to go in like 9 minutes. Apologies.
Yeah.
I know,
Can I say one thing, Adrienne? Because I think what Selchuk just said there was really important, and I hadn't thought about this before. Should there be a step at the end in the conclusion asking the question, going back to that first person narrative, how would this material change the way you look at this story? Would it change anything that you do as a health professional? If you were interacting with the person, based upon this sort of experience, given what we've talked about. So I like that idea of start with the narrative and come back to the narrative.
Yeah.
Excellent.
Laura, did you have any reflections before we go?
Sure. I I think it's a really interesting process. And as Adrienne said, she and I had been talking about how this is very different than the way we normally operate in medicine. And I think that it's hard, just thinking of me working with my residents and fellows and medical students, it's hard to get them to see anything but that end. And, you know, and that this ultimate goal that we need to get to, whether it's the board exam, whether it's the conclusion, whether it's the diagnosis or the treatment plan. And so much of this is the journey and the discussion and where it goes and how it evolves. And I think for me, the thing that I've learned in all this is just how many different lenses are there, and that sometimes it's really helpful to take a look and grab a different lens, because that allows us so much different insight and perspective. And I think that's been so valuable for me. And like I said, I learned a lot through the researching the police brutality that I'd never taken the time to do. And then recognizing that it really has an impact on healthcare. And I really think it's something we should teach, and that I don't know that, you know, at least at the University of Louisville, to my knowledge, that we don't teach. And so, you know, I think it's a gap. And so I think that's something that's through all this process has really just come to the forefront of my mind.
Thanks, and sorry if I was bossy about time, but just I appreciate people being here for this. I was just thinking, last thought was thinking about content in an end in and of itself versus content as facilitating process and perspective. And I think that's hard, right? When in such a goal-oriented setup in medical education. But I think you learn that as you go into practice, right? That you're always learning, and you're hopefully gaining new perspectives, and that's what vitalizes you over time. And so I think we would be remiss not thanking like all of the group members. We really had to band together to get this done. And that's always some of the joy of it. And also thank you to all the instructors, to Michael, Christy, and Sandy in particular, who didn't give up on us because we were ready to give up on ourselves. We were like, what are we gonna do? But somehow we pulled it off, and we'll edit it. We'll pull it together to edit it. But thank you so much to everybody for today.
Beautifully done. And it's been a
Thank
pleasure
you.
with all of you.
Definitely a pleasure having you guys in this class, and I've learned so much from all of you. And it's just been really a delight. You are all, God, I would go to any one of you to be my doctor. Which is saying something, as Christy knows. So thank you all for spending the time this summer, taking the class and opening your minds, and yeah, it's been a great experience. I hope you enjoyed it. And thank you. This is a wonderful portrait that we're going to use, right, Joanna? So thank you. All right.
Bye-bye.
Bye.
Thank you all so
Thank
much.
you, Sandy.
Thank you. Oh.